Thank you for the invitation. And I have many slides, so I have to run really fast. These are three of the characteristics of neuroendocrine tumor, and it's probable that all the three of these characteristics may increase in neuroendocrine tumor, but at least one is probably increased. So this gives us this unique opportunity, probably in oncology, to look at the same tissue from different point of views. So we can use many different beta emitters, radiotracers, to study neuroendocrine tumors. And today I will mainly talk about the use of gallium-DOTA or gallium-DOTA peptides that, as you know, is a marker for the presence of somatostatin receptors. As you probably know, there are many different peptides and many different radiotracers that differ slightly in the affinity to receptor number 2, 3, 4, or 5. And in our institution, it's in use since 2006, gallium-DOTA NOC, that is composed by three parts: a beta emitter, a chelating agent, and the active part that labeled with high affinity receptor number 2, 3, and 5. This is the normal biodistribution of the tracer. I don't know if it's possible to see. There is a normal uptake in the hypophysis, urinary excretion, and the spleen is the target organ. And just pay attention to this finding here in the head of the pancreas, because we will meet many times during this presentation and during the interactive session this afternoon. This is the normal biodistribution of the tracer. This is our first generator in 2006. As you probably know, the fact that the gallium is produced with a generator has many advantages. There's no need of a cyclotron. The half-life of the generator is about 9 months. It's relatively cheap, and the labeling time between gallium and DOTA NOC or other molecules are really fast, 20 minutes. And probably the only disadvantage is that the production is relatively low. This is our old generator. This is a new generation generator. But since the state of the art, let's say, in all over the world is still the Octoscan, let's see why we should move to the use of gallium-DOTA NOC or gallium-DOTA peptides. There are many, in my opinion, there are many advantages of gallium peptides. And we can summarize in these 5 points. First, it has a high affinity for receptor number 2, 5, and also number 3. It has a better spatial resolution of PET instead of SPECT, of course. It has a lower physiological uptake in the liver and the bowel, that it may be very useful sometimes. It has better dosimetry and a lower cost in comparison to Octoscan. And moreover, it's patient-friendly, 2 hours versus 24 hours. Since I didn't want to leave the right column empty, maybe the only advantages are that with AutoRide you can have delayed images, 24-hour images, that is not possible with gallium peptide. And of course, if your center do not have a PET scanner, you are forced to use Octoscan. This high affinity and this better spatial resolution sometimes may provide you very high quality images, like this characterization of this very subcentimetrical incidental finding, as you can see by the red arrow here, with a very high tumor to background ratio in the gallium-DOTA NOC. Or you can have subcentimetric lymph node with very intense uptake of the tracer, as you can see here in the left supraclavicular chain. Or you can characterize very small lesions in the CT with osteoblastic lesion in this case, or even early lesions without any structural alteration on CT, or characterize a small liver lesion like in this case, or this very strange case about the characterization of internal ear neuroendocrine tumor. Or the fact that you have a low uptake in the bowel sometimes may provide you the detection of the primary tumor. You know that CAP syndrome is relatively frequent in neuroendocrine tumor, and as you can see here, this patient was diagnosed with 2 liver lesions. We underwent a gallium scan and we detect the primary in the bowel. And of course, this results in a much better accuracy in comparison with Octoscan. This is one of the few patients we scan in double. We stopped after 5 or 10 patients in 2005 or 2006, I don't remember, but we only scanned 10 patients with the dual tracer, Octoscan and gallium dotatate, and then we stopped. Now we don't do any more Octoscan since 2006. And of course you can see a much better tumor to background here in this region in the abdomen, and the fact that you can see these 2 faint uptake in the liver resulting in the liver metastasis, they were not visible on Octoscan. This has been reported already since 2007 by the group of Innsbruck, and in Austria a much better sensitivity and of Octoscan, of the gallium dotatate in this case in comparison to Octoscan, and was also confirmed by a recent study by a group in London. They studied only patients with negative or inconclusive findings at Octoscan, and they found out a significant better sensitivity of gallium dotatate, as you can see here in these nice pictures. Another advantage is that you have a favorable dosimetry, as reported by a group from my hospital. You can give 1/3 of the dose. The students starting the patient with gallium dotatate instead of Octoscan. And last but not least, at least in Italy, it's much cheaper. It's almost the half price. This is a German study, referred in euro, but as you can see, you have about 550 euro for gallium dotatate and 830 euro for Octoscan. So, in conclusion, I think really I have not only found interest, but I think there's even we heard a speaker yesterday from London that he tried to convince for 2 years that gallium dotatate or dotatate is better than Octoscan. In our department it lasts like 1 week, and so after 1 week of double tracer we moved to Octoscan. But there are dotatate, I'm sorry. But there are other tracers that may be useful in neuroendocrine tumors, and one of these is fluorodopa. And let's look at the potential advantages of DOTA peptides. Okay, of DOTA peptides in comparison to fluorodopa. This is the first and most important advantage, because gallium dotatate peptides, they provide information about the somatostatin receptor status, so they can influence treatment options, something that fluorodopa cannot do. The second is that the synthesis is much easier, cheaper and faster if compared to the one of fluorodopa. And the third, that the DOTA peptides show a better sensitivity in most of the neuroendocrine tumors, and this has been established already, mostly in gastroenteropancreatic tumors and in bronchial carcinoma. One of the advantages of fluorodopa is the better sensitivity that has been already established in medullary thyroid cancer in comparison with gallium dotatate. And maybe this is a very gray zone. Maybe it may provide some reliable information about response to therapy after radioreceptor therapy. But this is, I don't want to go into the details in this case, because maybe we can leave open for discussion after. And this is a patient study with fluorodopa and gallium dotatate. As you can see, most of the lesions in the liver are not detectable in in fluorodopa scan, and also fluorodopa has a not very favorable biodistribution, because you can see here there is a faint uptake that is physiological in the pancreas. You can give medication to avoid this, but in any case you can give carbidopa before the scan, but in any case this is a problem. And then this is also physiological. There is intense uptake in the gallbladder. This is another impressive case. This is the gallbladder. This is not the lesion. This is the pancreas again. As you can see here, it's possible to detect the lesion at the primary, large primary here, and multiple liver metastases with calendrodopa, but not with fluorodopa. And this has been published already by our group. As you can see here, in only 14 patients with neuroendocrine tumors, gallium dopa detect almost double of the lesions in comparison to fluorodopa. And this has been confirmed by a German group a couple of years later with absolutely similar results. But, as I told you, in medullary thyroid cancer, this is the opposite. So if your clinician wants to study a medullary thyroid cancer, probably I will not suggest gallium dopa as a first step, because it has been demonstrated, as you can see here, that fluorodopa may detect double the lesions of gallium dopa. This is a study in only 18 patients in any case. As you can see here, this is fluorodopa, this is FTG, and this is gallium dopa. And this is the same patient, as you can see, fluorodopa absolutely positive, FTG negative, and gallium dopa cold lesion. And now another chapter that is, in my opinion, very, very important. The synergic use of gallium dopa and FTG. Remember that FTG is not useless in neuroendocrine tumor. Otherwise, it's very important to know that FTG can be very useful in neuroendocrine tumor. And sometimes the Q tracer may have complementary information, may provide you with complementary information. This has been already demonstrated many years ago that in a highly differentiated neuroendocrine tumor, it's better to use gallium dopa or DOTA or whatever, and with poorly differentiated, probably FTG is better than DOTA peptides. This has also been demonstrated recently by always the group of Professor Bomangi, and in low-grade tumor, you can see here that the uptake of gallium dopa is very high, and the uptake of FTG is relatively low. In atypical or poorly differentiated tumor, the uptake of DOTA is low, and the uptake of FTG is relatively high. And this is related probably to the expression of the Ki67. As you can see here, this is a patient with multiple liver metastases. Ki67 was 20%. As you can see, a cold lesion here with gallium dopa, but FTG positive here, as you can see here by the red arrow. Same patient. A gray zone, Ki67 4%, faint uptake of FTG, intense uptake of gallium dopa, well-differentiated, moderately differentiated neuroendocrine tumor. Or you can have the opposite. This is a very interesting case. This patient was referred to our center for a CAP syndrome with multiple liver metastases, for sure secondary lesion from before the biopsy. So we start with FTG. FTG resulted to be completely negative, but the patient had symptoms of flushing and diarrhea. So we perform a gallium dopa scan, and we detect multiple liver lesions, not only, but also, as you can see here, also the primary tumor. But just remember that FTG has a very important prognostic factor. An FTG positive or FTG negative may do the difference between large disease-free survival or short disease-free survival, as demonstrated by this very well conducted paper from Germany, and also demonstrated very recently, 3 weeks ago, has been published in the European Journal of Nuclear Medicine, a study from Italian group. They studied 52 patients with neuroendocrine tumor, grade 1, with Ki67 lower than 2, so well differentiated, and grade 2, Ki67 between 3 and 20. They studied only with FTG, and the results are very interesting because they reach a complete, let's say, partial response, complete response, or stable disease in 100% of patients with FTG negative PET, but only in 75% of FTG positive PET. So this means that there is a very impact on the outcome of the patient depending on FTG. So if you want to know the prognosis of your patient, maybe you may scan not only with gallium dotanate but also with FTG. And this is something that is happening more and more frequently from the clinician. They ask both. They ask gallium dotanate and FTG since the beginning. But don't forget, however, that also gallium dotanate may provide you with a very interesting prognostic factor, and we publish our department published a paper in JNM in 2012, and taking as a cutoff the SUV max higher than 19, as you can see here. This is the most important and relevant predictor factor, together with the differentiation of the tumor, as you can see here. And the multivariate analysis here is the most important predictor factor. If you have a very intense uptake of gallium dotanate, it means that you may have a better survival curve or disease-free survival curve. So we will talk about pitfalls of gallium dotanate peptides later on this afternoon, but just remember a couple of things. And the first and most important is this one. Nobody knows what is this. This is a take in the head of pancreas, mostly in the uncinate process of pancreas, and it happens about 20-25% of the times, and you can have a faint or diffuse uptake or focal uptake. We studied this finding and we published our results in the Journal of Nuclear Medicine in 2011. We studied about 250 scans in sequential, so 100 patients studied with 2 or more than 2 gallium dotanate, and we found out that the frequency is about 25% of diffuse or faint pattern, the one that I showed you before, but also in 5% of the cases you can have also focal uptake. That does not change, does not disappear after 2 or 3 years. And we will talk about this later on this afternoon. And second is that activated lymphocyte may express, even intensely express, somatostatin receptors, as you can see here. This is a patient who studied with gallium dotanate for another reason, but he had also a sarcoidosis, as you can see here, intense uptake in the mediastinum, and if you look at FTG, it's absolutely the same, as you can see here, maybe larger, but absolutely the same. So remember that you may have some false positive results. This comes from the fact that activated inflammatory cells overexpress somatostatin receptors. So in conclusion, I think that gallium dotanate peptides, whatever you want to use, may have many advantages in comparison with other radiopharmaceuticals. They have an high accuracy in staging or restaging most of the well-differentiated net, except of medullary cancer. They can provide, this is very important, they can provide information for radioreceptor therapy that you cannot have with fluorodopa, FTG, or 5-hydroxytryptophan, whatever you use. they have a lower cost, a better dosimetry in comparison to Occluscan or fluorodopa. But remember, however, that DOPA is more sensitive to gallium dominant in medullary thyroid cancer, and FDG is not useless. It can use FDG to have prognostic information. And I think that Google Translator translated well. Grazie per l'attenzione, and thank you so much for your attention.